scene has already been set by the excellent talks earlier today. There is a national SCE conference taking place today, so I am third choice because the first and second choice are perfect. But I'll try to do as much as I can. So I will hopefully give some background to the national SCE program and what we are planning to do locally as well. We all know and have been told multiple times that the NHS has a phenomenal data resource. It has been collected for tens of millions of patients over the course of many decades and presents the opportunity to improve NHS care and drive innovation. It is also a research resource of global importance because compared to other similar data sets in other healthcare settings, it's much larger and the population is much more diverse. So raw data is not powerful on its own. It often sits in silos and can't always be trusted. It must be validated and curated. And traditionally, we've relied on multiple data projects, some of which we can talk about today, which don't always join up. Quite often, you lose the richness of the data as part of the extraction. You end up distributing overlapping data sets to different organizations, and this duplicates data preparation and governance. While the NHS data systems aren't always completely secure, you potentially increase the risk of data breaches every time the data leaves the NHS system for secondary use. And there's been various examples of that. There's also an increasing recognition of the commercial value of data within the NHS. And this brings with it concerns from patients about whether their data is being used responsibly and whether the NHS is getting fair value for providing this data. On the background is the Gold Acre Review was commissioned by the Department of Health and Social Care to explore the best practices in making NHS data available for research. They published a report in April last year, which made several recommendations, but the key ones were around building trust with patients by making sure that the data is secured and its users contact. They recommend that we build a small number of secure research environments which have analytics tools like XMAP, which I discussed earlier, to facilitate research. More controversially, it recommends that the NDE should be the only way data should be conducted. And clearly, we're well away from that yet, but that's the direction of travel. The recommendations were quickly followed by a policy paper, which said the direction of NHS travel. And this is very much around research to the NHS rather than data to external parties. The hope is that the SDEs will improve trust in the NHS data use, provide operational data that supports local and national decision makers, empower researchers with the data they need to develop and translate diagnostic technologies and treatments, and facilitate development and validation of new commercial innovations that improve healthcare. This needs to be underpinned by a technical infrastructure to facilitate the above, and the SDEs need to develop a value sharing framework to make themselves sustainable. The SDEs will aim to facilitate data sharing based on 5 key principles. So the first is patient benefit. Any use of NHS data must have the explicit aim to improve the health and care practice. This may include discovery of new treatments or diagnostics, as well as operational improvement. Where possible, data requirements specify what the benefits are likely to be. The NHS organization should ensure that they agree fair terms for sharing the value generated from the data. And again, there was a discussion earlier around universities relying on the NHS to provide data for innovation, and that value chain doesn't always fit back into the NHS. So locally, that's been a big one of contention. NHS organizations should not enter into any exclusive data arrangements for our data, and data sets that should be reusable at the local and national levels. All data sharing agreements should be transparent and clearly communicated in order to support public trust. Whenever data access is made, it should be audited, and requests should adhere to all the applicable national level legal and regulatory obligations such as GDPR and the protocol guidance. To support this, there was a headline amount of 200 million announced to provide the setup of infrastructures. How much of that filters through, we're not quite sure yet. But the vision is to have a national security environment supported by up to 11 regional environments. The national SCE is initially intended for supporting service planning and population health, while the subnational secure data environments will be focused more on supporting research. The Thames Valley and Surrey SDE, which is sort of where I'm involved, is one of the first wave in the first wave of PSTs, and there'll be 7 following in wave 2. Our SDE covers quite a wide region with multiple care settings, including primary and secondary care, as well as mental health and ambulance services. It covers a large and varied population. Oxford University Hospital is the lead organization and has the university as a strategic partner, but the vision is to join us with other SDEs across the country and share the data and expertise nationally. This will hopefully provide richer data sets which build a more complete picture of patient journeys across multiple organizations. I think hopefully also encapsulate greater diversity in population, but also in care settings. And again, hopefully there will be easier access to high quality data because you'll be reducing unnecessary bureaucracy and hopefully reduce cybersecurity risks as well. We are at the early stages of development, which is why a lot of hopes in every sentence I say. So far, we've been working on getting the providers agreement signed and aiming to have comprehensive data flow from Oxford by Easter, with other sites to follow over the next year. At the same time, we have a number of engagement activities planned to understand the data requirements from the academic and commercial research partners. We also have some exemplar projects to demonstrate the value of the SDEs and to iron out some of the teething problems which I'm sure we'll encounter. On the governance front, we have approval to pull identifiable data for multiple care settings to be linked within the SDE. We also have delegated ethics for retrospective research studies, which is not tied to a specific project. So data access approval for a particular project can be provided at local level. This approach has now been endorsed by the National Council of Protocol Guardians, who propose that all SDEs adopt this model going forward. The getting a business case approved by the trust has been quite a challenge because we're supposed to achieve sustainability in 2 years, but we've now got that in place. The technical infrastructure is built on some work we've done previously. It's been coded over at Microsoft and brings with existing infrastructure developed as part of our Imaging Excellence Center for NCB and the Oxford BRC. At a high level, there is an internal and external facing aspect of the SDE. The internal facing aspect will allow review and curation of the data of identifiable data. There will then be an externally facing tools that allow de-identified data to be reviewed and processed, and data to be extracted if needed. What we're aiming to do is provide an opportunity for the researchers to be able to see the data and link further. So rather than having data sets which are exported at point in time, there is a linkage in place for researchers to go back and get additional information at the patient level if they need. And hopefully get multimodal data, so you can really leverage the power of big data. Rather than having fat descriptions and having ground truthing at one point, we want to have the ability to look at the raw data and establish a ground truth if we need to. But hopefully provide the infrastructure to do that in a secure way. Initially, we want to create a master patient index so we know what data we host, what patient demographics we have, what technical from an imaging data perspective, what technical demographics we have, look at the existing data extracts and data flows across different organizations. We're focusing initially on imaging, so radiology being a big one, but also digital pathology and endoscopy imaging, with this data being paired with reports, biochemistry, and then cancer tracking and MBT outcomes, as well as treatments. We've had a number of workshops with patients, public and healthcare professionals. The first one was around what should go into the SDE, what should it be used for, who should be able to access the data. We've also looked at what data value and transparency means for patients, and how to record these when servicing data requests. Some of the initial exemplar projects are around imaging, and we're using the data from the SDE to conduct multi-case, multi-reader studies. These are being done on smallish data sets, hundreds to thousands, rather than tens of thousands. And we've been working with commercial partners to validate chest X-ray, fracture detection, and CDN algorithm. An overview of this might be that we have a centralized platform which can be used to query SDE image data set. We then have APIs in place where image images can be inferenced from different AI developers. We have a cloud interface where experts can access the image with ground truth, and we can present both the raw data and the inference data to clinical readers from different sites to be able to provide an image. Because a lot of the algorithms at the moment are decision aids, so you want to be able to see what their impact is on the end user who are using it. Going forward, we're curating large imaging data sets for independent AI validation, initially looking at chest X-ray, fracture X-ray, and SCTs. And hopefully what we aim to be able to have is a dashboard which looks something like this, where you've got an algorithm, where you've got data broken down by its accuracy broken down by different scanners, different age, patient ages, patient demographics, and then also different findings, because at the moment the algorithm provides findings in different categories, and we want to be able to say how well they perform in different categories. But we also want to have the tools to be able to drill into that data so you can then see if the algorithm disagrees with the primary data. Because this is real world data, you don't know whether the person interpreting was an SCT radiologist or was a chest subspecialist. So you want to be able to dig into that data and work out was the algorithm wrong or not, having misclassified the primary diagnosis. But also provide feedback to the AI developer around where their algorithms do well, where they don't do so well, and how we can improve that in the future. We're also working on multimodal data sets. So we're doing the DART project, which is data using AI to improve patient outcomes with thoracic diseases. And in this, we're collecting data from clinical data, CT data, digital pathology, and blood biomarkers from targeted lung health checks, and integrating in one place. And this can then be used to develop new AI tools. Beyond imaging, we're looking at other use cases for AI, and sort of, again, this is building on existing research that's happening within the SD footprint already. But what we're trying to do is bring this in so we can support this kind of project going forward. So things like early warning score system for sepsis and obstetrics, real-time decision support for antibiotic and cancer prescribing, and then finally looking at large language models around data summarization, and both for MDT purposes, but also for patient communication. I'll leave you with this image, which has been prepared for the public and demonstrates the flow of FTE data and knowledge. It hopefully shows the virtuous cycle of how the FTEs will deliver for the benefit of NSF and its patients. Thank you.